Okay, that's really helpful. I'm going to go to some of the questions that have been submitted, and I'm going to start with this one because there's been all sorts of things on the news these days about people with immune compromised systems because they're on immune therapies not necessarily showing any benefit from the COVID vaccine. So the question is, do immunotherapies degrade or negatively impact the COVID-19 vaccine efficacy? And if so, what precautions do you recommend?
Yeah, great question here. So I haven't seen any data in bladder cancer that suggests that the COVID vaccine is less effective if you're getting immunotherapy. There was some data, especially out of New York during the earlier parts of the pandemic, that some patients who were on immunotherapy treatments, that they were having worse outcomes if they contracted COVID. Okay, that those patients were actually doing worse, which almost seems counterintuitive, right? If you're on a drug that's stimulating your immune system, you think, well, maybe I'd be able to fight off COVID better. But actually, it seems like those patients were getting really strong inflammatory responses and having complications in the lungs because of the overinflammation in the lungs. With respect to the vaccine now, I'm counseling all my patients, certainly cancer patients, but all patients, to go ahead and get the COVID vaccine. What we've done for patients that are on immunotherapy is that we've, if the patient's been on immunotherapy for a long time, we go ahead and just get the COVID vaccine. If a patient's thinking about just starting an immunotherapy or a chemotherapy, we've tried to separate the timing of those by at least a couple weeks. But I don't know of data that that the vaccines do not work. I have not seen that.
Mm-hmm. Okay, and I think we're just now beginning to really start looking at all of these things. So I'm sure that there's going to be evolutions of our knowledge and articles that come out that are demonstrating whether this is an issue or if you need to have an extra booster or whatever. So I think that there's a lot of TBD, to be determined, when it comes to understanding the vaccine since it's so new, and then how does this impact us with immunotherapy. So thank you. It's a great thing, great question to have answered. I have a couple other questions that I will ask. What do you think about beta-glucan with immunotherapy? Dr. O'Donnell, can you speak about that?
Yeah, so this is one that not a lot of my patients have asked about. I know that beta-glucans are being explored for the treatment of lots of different types of cancers as a way to sort of boost immune responses, but they're not proven yet. They're still have an experimental role in cancer treatment. And I haven't had personal experience with using them. I don't know if Mr. Coons or Ms. Sperling have used other supplements or nutrients to try to boost immune responses.
No.
Which leads to another question. Is there anything that patients and their families could do to enhance this immune response, whether it's diet or exercise or anything else that they should be paying attention to as they're going through the treatment?
Yeah, I don't know, Mr. Coons or Ms. Sperling, do you want to comment on that? Because that's something I think we have talked about at various points, the things you're doing in your own lifestyle, and then maybe I can chime in as well. Patients ask this all the time. Now, what can I do, Doc? Is there anything else I can do? Are there things that you feel have helped both of you?
Well, I like to walk. I walk, I don't know, about 3.5 miles a day. And when it's nice, I'll play golf once a week. So I do just regular living, I guess is the only way to put it. It's not holding me back in any way. So, Lynn?
Yeah, I exercise. I go to an exercise class 3 times a week. It's a sitting exercise. It's called Sit and Get Fit. And I think a positive mental attitude too, being social, being with friends is also very helpful.
I love that. I'm a big proponent of the idea of some form of exercise, because I think there's clearly data that exercise improves immune responses in general, even in the absence of immunotherapy. So I think it's healthy for the immune system in general. And I love the mind-body comment there, Ms. Sperling, because there's a lot of data actually around that positive influences in your life can actually have positive outcomes.
Yeah, attitude is everything. I do believe that. Attitude determines your altitude in many cases. I think that really does apply here. but it's not always the case. So there are plenty of people that have real issues. So if you have immunotherapy and it causes your immune system to overreact, Dr. O'Donnell, can you explain how the steroids help kind of quiet things down, and then, you know, you gradually start back? So you start back with a lower dose. How do you fix that problem and still maintain the benefit of the immunotherapy?
Right. So this is where, you know, you're really going to need to rely on your doctor understanding what severity of the inflammatory response are we seeing. You know, some small degree of inflammatory response, like Mr. Coons talked about, a little bit of itching that he has. I actually tell my patients it's probably a good thing. It tells me the immune therapy is doing something in your body, right? That it's activating, that you're getting a little bit of a response. And as long as, you know, you can still function and it's tolerable, then, you know, we wouldn't do anything differently. That would be sort of what we call the least severe form of an inflammatory response. A second grade of it would be where now it's starting to cause you to be a little bit limited in what you would be able to do. For example, you know, a rash that's covering a good portion of your body where, you know, now it's requiring more intense treatment than, you know, a large amount of cream over your areas of skin, where it's, you know, limiting your ability to, you know, walk because of skin folds being rubbed against. That's where we start to say, all right, now this is becoming a little more severe, and we're going to probably pause that immune therapy, meaning we're going to withhold the drug for a while, give some topical treatments to the skin there, and maybe even a short course of an oral steroid, a steroid pill like prednisone. And then beyond that are what we call the higher grades, the more severe. We call them grade 3 and 4 immune events. And these are ones where the patient has clearly had organ dysfunction. For example, a patient has severe diarrhea because the gut has become so inflamed, or is having shortness of breath, or lowered oxygen saturation because the lungs have been inflamed. These would be instances where your doctor should hospitalize you immediately, and you're going to get high-dose IV steroids through the vein, a drug like prednisone or a similar drug through the vein, to calm down that immune response. Typically, doctors will need to use that high-dose steroids for at least 48 hours in the hospital, and usually within that first 48 hours, we see patients dramatically improving. The diarrhea will quickly reverse, the skin rash will quickly improve, the breathing will improve. And so all of those are the metrics that your doctor is looking for. And then what they will often transition you to is then an oral pill of steroids that often has to be tapered over a period of at least a month. So they'll discharge you from the hospital, you go on an oral steroid, and that steroid dose will be slowly lowered over the course of a month or 6 weeks until the steroid can be taken off. And then the real question is, once that steroid comes off, is your body going to re-inflame? Is the immune system going to reactivate? I talked a little bit about the idea of your immune system getting a memory to it. And so it can have a memory around these side effects as well. And so sometimes when we stop the steroids, the immune effect that you were having flares right back up. And that's troublesome, because then we have to put a patient back on steroids. And many patients know that steroids for long-term, you know, are not fun to take, right? They can cause patients to have sort of swelling, you know, the face will puff up, you get very hungry, and people will gain weight, you can retain fluid. There's lots of side effects of long-term steroids. And so that's the problem when we get these severe immune, you know, adverse effects. And really your doctor then has a real tough question about whether they could ever go back to immune therapy. One little trick that I have done, and I'm a believer in this, is that if your patient gets a severe immune related adverse event and then improves, and you have a discussion where that cancer is then growing again one day, and your patient says, you know, doc, I want to fight, I want to do everything I can, and you have no other options, I'm willing in those cases to consider going back to the immune therapy, but that's when I switch it, right? We have 4 drugs that are out there on the market. I definitely wouldn't give the same one again. I'd switch it to a different type in hopes that that inflammatory reaction doesn't come back in the same way. Mm-hmm. And I know somebody was asking a question too, Stephanie, about lowering the dose of the immune therapy. Generally, that's not helpful. So with chemos, we will, you know, reduce the dose and the side effects usually improve. With immunotherapies, we don't see that.
Okay, that's great. Well, I remember in your talk, you had that really lovely slide that to me was very encouraging, where you're showing the difference between the killer cells going after the tumors with those immune therapies. So that leads me to another question that came in. To what extent is the presence of immune cell infiltrates in a tumor biopsy of predictive value? Do they even check the tumor to see if those killer cells are activating? How do they know, unless they actually see tumor shrinkage, that it's starting to work, that you should continue on this therapy? How do they know that?
Yeah, great question. Yeah, right. So in most cases, we don't do a follow-up biopsy, right? It's not that we start the immune therapy and then we do a biopsy and try to see if those immune cells have infiltrated. The slides that I showed you there have been, from research experiments where this has been looked at to show that it actually correlates, right? That the infiltration of these immune fighting cells actually correlate with the patients who do better. But in regular practice, that's a lot to put on a patient, right? To say we're going to do a biopsy just to see if those immune cells have infiltrated. Usually you can tell, like you said, Stephanie, by doing that scan. If the scan shows that the cancer is shrinking, then we know that probably those immune cells are getting in there. One sort of thing that we're thinking about for the future, though, is what do we do if a patient doesn't seem to be responding to the immunotherapy? It probably tells us those immune cells aren't getting in there. Is there a way to try to do something else to those immune cells and really kick those immune cells, those killer cells, to get in there? And that's where the field is probably moving, the idea of these double immune therapies where, maybe in a given patient, for whatever reason, they're not responding to one immunotherapy, but that second one might help those cells to get in there. And we're learning about that. We're also learning that there's actually different types of bladder cancer. Patients probably are familiar with that. And that there are now tests where we can categorize a patient's tumor into ones that are likely to have the immune cells that will infiltrate, that might already have immune cells that are sitting in there and they just need to be turned on, or cancers that don't have any immune cells. We call them immune deserts. For whatever reason, that cancer just cannot find immune cells in it. And so those are tests that your doctor could do nowadays, although they're not done in routine clinical practice.
Okay. You mentioned, Dr. O'Donnell, that BCG that was given to patients with non-muscle invasive disease who didn't respond to the BCG could possibly get pembrolizumab. Is that something that's given intravesically like BCG? And do you have to be in a clinical trial, or is that something that you can just get, off-label perhaps?
This is on label. This is an FDA-approved indication for pembrolizumab, the Keytruda drug, now, as of the past, a couple of years now. So it's more recent, and I'm actually seeing that not a lot of the patients are aware of it. Even doctors are sort of still slowly recognizing that this is an option. So it's exactly what you said, Stephanie. The patient where their cancer hasn't yet invaded into the muscle layer of the bladder, they've been through BCG, and technically those patients also have to have that CIS component, that carcinoma in situ feature of their bladder cancer. Those patients are eligible to get pembrolizumab on label as a way to try to prevent further deep progression of that bladder cancer. In my own practice, I've used it rarely. It's just we're having trouble finding a lot of patients that fit that very specific label indication right now for pembrolizumab. But a lot of us wonder if we're going to start using immune therapies earlier and earlier in the disease course, right? That's one example, right? Why wait until you have metastatic disease to use immunotherapy? Could we use it earlier? Could we use it around the time of your bladder being removed? Or in this case, as you're saying, even earlier before it's invaded the muscle?
Right. So now as a medical oncologist, you're used to using chemotherapy. So if a patient benefits from chemotherapy, is the recommendation moving towards all patients going to some kind of maintenance with immunotherapy? Is that where we're really heading? That, just make sure once we get it knocked down that it stays down? Is that what we're looking at?
Yes, that's become the new standard, where I think almost all patients are really offered that now, this idea of maintenance. I mean, in Mr. Coons' case, we're doing exactly that. We're doing a maintenance immunotherapy approach where we're going to probably do this indefinitely, right? If it's not broke, why fix it, right? That kind of idea.
Mm-hmm. Right. And if for whatever reason, then if immunotherapy no longer is effective, if it's not getting that response, then you've got the targeted therapies as yet another option. So there's still quivers, arrows in the quiver, but you don't necessarily focus just on the immunotherapy because there are still other options. So for instance, in Lynn's case, if her cancer were to come back and she didn't respond to immunotherapy the next time, there would be other options.
Right.
Right.
So yeah, I saw that. What you're just asking about, Stephanie, there, I see that in the chat, right? That someone's asking about that. You know, this idea of waiting for the cancer to return. We're moving away from that in bladder cancer now. With just over the past year, you know, this idea of going straight from chemo and going into that maintenance immunotherapy.
Kind of like with your car, you don't necessarily wait for it to break down before you get it fixed. You do routine maintenance to just kind of make sure it keeps running smoothly, I guess, in that case. Lynn, this is a question for you. There was a question, do you still have your bladder? And were there tumors that were high-grade tumors? Somebody is receiving BCG and they're in an 18-month trial. And they want to know, do you think immunotherapy is something they should consider? So Lynn, if you talk a little bit about your experience, and then Dr. O'Donnell, as the experts, could you weigh in on that?
I still have my bladder. I originally had some surgery to remove what the cancerous growth in my bladder, and it had escaped to the lymph system. And that's why they were treating me with chemo. And that's how I got, you know, referred to Dr. O'Donnell. But yes, I do still have my bladder.
Stephanie, can you clarify sort of what part of the question you want me to comment on?
Well, it was just in terms of, I just dismissed the question, so I just lost it, and I was reading all the other ones. So now I'm sorry, I just can't.
Well, does it have an effect on tumors still in the bladder? Is that sort of what you were asking?
I think so, yeah.
Well, I mean, that's sort of what I was talking about before, where, you know, we're seeing, you know, immunotherapies have an effect on even tumors that haven't invaded the muscle. We're wondering whether immunotherapies will have an effect on tumors that are muscle invasive, right? I think one of the questions is around that. If you have a muscle invasive tumor, is there a role for immunotherapy there? And that's still under exploration, but there's been a couple trials now published that show that even patients with tumor invading in the muscle might have very nice responses to immunotherapy. Not everybody, but some portion of the patients having a response to that immunotherapy. And so the idea is that maybe we can use immunotherapy either before we take that patient to bladder surgery to shrink down the tumor and try to eradicate any microscopic cells that have escaped. Or one study that just came out this year, which was really exciting to all of us in the bladder community, is for a patient that's gone through bladder surgery, and yet they have high risk features, that bladder had tumor that was maybe farther invaded than we hoped. Those kind of patients are at high risk for that cancer coming back, because the cancer cells had an ability to perhaps spread where the surgeon can't even see that they've escaped beyond the surgical field. Those patients now might be candidates in the near future for using immunotherapy as a preventative to prevent the cancer from coming back. So it goes to that whole topic we were talking about, you know, preventative maintenance or maintenance immunotherapy. If your cancer is already spread and you've been through chemo, we're now doing maintenance immunotherapy. In the near future, I believe we might be thinking about immunotherapy post-surgery to prevent the cancer from coming back. That's still unproven, though.
I know that you're involved in many research trials. Do you see that there might be something 5 or 10 years down the road where perhaps immunotherapy would be used as a first line in muscle invasive disease in lieu of getting your bladder removed? Do you think that that's something that we're just trying to understand if that's a benefit? Where are we going in that direction?
Maybe. I want to be careful answering that one because, you know, patients need to be clear that if your cancer has invaded into the muscle, the gold standard, the standard of care is that that bladder needs to be removed to save your life. And so we really get into dangerous ground thinking about trying to spare the bladder there in those patients, because, you know, I've seen too many times where patients delayed, you know, having their bladder removed and they die of bladder cancer. So maybe, you know, maybe we'll be using immunotherapies along with bladder removal. Or I know that there's one question in the Q&A about combining this with radiation treatments, right? Some patients who opt to try to keep their bladder will use radiation treatment, treating the bladder cancer in its place without removal of the bladder. That is an option in some patients, even for when it's invaded into the muscle. And so there's actually studies going on now to say, can we combine immunotherapy with radiation to have even better outcomes for saving the bladder in place?
Right. And what you were mentioning before was a little bit more like neoadjuvant chemotherapy. I always use the analogy of it's like putting the evil genie back in the bottle before you take the bottle and throw it away, which is what happens with removing your bladder. You want to make sure everything gets into that bottle and then you take it out. So that's basically being used now in some cases the same way as neoadjuvant immunotherapy before the main treatment, which is the surgical removal of the bladder. Okay, great. This is all good. I'm just checking on questions. There was a question in here. I think it's really relevant because a small portion of our patient community has what's known as upper tract disease, where their cancer is not necessarily directly in their bladder, but perhaps up in the ureters or even in the renal pelvis of their kidneys. Is immunotherapy being used in that case at all? Have we seen any benefit for those patients?
Well, it's being studied there. Although, you know, patients who have upper tract urothelial cancer, the type of cancer is actually the same. You know, a urothelial cancer that can start anywhere along the urinary tract. I saw one question asking about urethral tumors, right? That's, you know, the very end of the urinary tract. That can be a urothelial cancer. The bladder, of course, is a urothelial cancer. And then the ureter, which is the tube connecting the bladder up to the kidney, that's a urothelial cancer. Even the first portion of the kidney itself, what we call the renal pelvis, is actually urinary cells. And so anywhere along that whole tract is where urothelial cancers can form. And so we end up treating, you know, the urothelial cancer wherever it forms along that tract in a very similar way. And if it spreads, if it metastasizes from an upper tract urothelial cancer, immunotherapies certainly have a role. The last thing I'll say about upper tract cancers is that we're learning that they do have some differences from bladder cancer, and that is much more likely that a patient might have a genetic syndrome that predisposed them to getting an upper tract cancer. Lynch syndrome, for example, is a genetic syndrome that maybe some people have heard of. It's commonly known to cause colon cancers and endometrial cancers, but it's now more recently been shown to be associated with urothelial cancers of the upper tract. So your doctor should be thinking about whether maybe you have Lynch syndrome if you've developed an upper tract urothelial cancer. The other genetic aspect that we definitely realize nowadays is that you're much more likely to have one of these mutations in a specific gene we call FGFR, which has a targeted drug that's now FDA approved. We didn't get to talk too much about targeted therapies, but if you have an upper tract urothelial cancer, your doctor should be thinking about these genetic aspects.
Mm-hmm. Okay. A good question is in here relating to starting chemotherapy. It's not necessarily related to immunotherapy, but how long do you go on chemotherapy before you say, I give up on this, it's not really working for you, let's go to immunotherapy?
I feel like I'm talking so much. Ms. Sperling, do you remember sort of how we made that decision with you? I'm putting you on the spot a little.
They 6 rounds, and that's when the oncologist said I had some choice to make. And so it was 3 weeks on, 1 week off, and that there were 6 of those before they decided that I could, you know, talk to you about immunotherapy.
See, I knew you were going to know the answer.
So
that's
6 months then. If there were 3 weeks on and a week off, or 2 weeks off, it was like 6 months before, you know, before you could really be considering or should be considering, because we still know that the chemotherapy is still the gold standard. It's still what's recommended first as the first line in many cases, right?
Right, for most patients. And Ms. Sperling is exactly right. Generally, the rule of thumb is that, you know, you don't go beyond around 6 rounds of the chemo. You know, after 6 rounds, the side effects really just accumulate. Very difficult for a patient to tolerate beyond 6 rounds. And we really don't see a lot of bang for the buck after 6 rounds of chemo. The effect is usually completely gained at that point. I tell my patients, you know, we're going to try to plan for somewhere between 4 and 6 rounds of the chemo. I'd like to get you through 4 if we can at a minimum, and then we'll see how you're feeling, and we'll kind of play it by ear. After 4, we'll see how you feel. If we can go to number 5, and then we'll see if we can get to number 6. But if you have to stop, I tell my patients, don't feel bad if you have to stop after 4 rounds of chemo, and then we can switch to the immunotherapy maintenance like we talked about.
Okay. Well, this is a very specific question. You may not have the answer, but how do you tell if symptoms or a side effect or possibly a cancer recurrence, such as genital ulcers, that would be down in that area? How do you discern that that would be perhaps a side effect, or is it a recurrence of your cancer?
Yeah, that's a real tough one, because I rely really on what was the presenting symptoms for that patient when they were found that they had cancer in the first place. And I do get a little nervous if a patient now is starting to have a similar symptom as when their cancer was first found. That really sticks with me. I've had many patients that say, you know what, doc, I'm developing a sort of a symptom that it was exactly like when my urologist first found the cancer. That is something that I would pay attention to and probably think about rescanning that patient to see what's going on. Immune-related side effects like rash, they're usually more generalized and not specific to just one area of the body.
So, Dr. O'Donnell, and Andrew, you're still on the immunotherapy. Is there an upper limit to how many years you should be on this treatment? Are there things you should watch out for long term?
Go ahead, Mr. Grins.
Oh, I'm feeling fine. I do each month before I go in, I have my blood tests, and doc goes over it, and they don't mix the chemicals until he approves that I'm good for that treatment. So I don't have a problem with it because I know that I'm being watched closely each month.
Yeah, I'll say that there really isn't an upper bound. Some of the trials have proposed stopping the immunotherapy after 2 years. It's a bit arbitrary. There's not a lot of evidence around that. And Ms. Burling, I think in your case, that's kind of what we did. So there's some data that suggests you could stop after 2 years if you've had a really nice response. But in other cases, a lot of my patients, I counsel that we're going to do this indefinitely, as long as you're not having side effects from it. Because I've unfortunately had a number of patients where when we do stop, the cancer then starts coming back.
Mm-hmm. I just
Are there
wanted
things
to add,
long term? I'm sorry, go ahead, Lynn.
I just wanted to
Go ahead,
add that
Lynn.
I actually had full knee replacement after I stopped the immunotherapy, and it went fine. And with the doctor's permission and everything, I had been putting it off, but that went very well, so I now have 2 new knees, one from before.
Ms. Burling, I remember in your case, one of the reasons that we ended up deciding to stop the immunotherapy was you did have sort of chronic fatigue that we thought was related to the immunotherapy. And I think that did get better after we stopped.
Yeah, a little bit. Mm-hmm.
Mm-hmm.
So these are the kind of things we weigh, Stephanie. Yeah.
Okay, so what other things should people be aware of if they're going, into their 3rd year of immunotherapy? What are some of the things that maybe they should consider having checked? Is there something metabolic that they should be aware of? Something that they should be telling their doctor, because they might not think to tell them about something that doesn't seem like an immune response problem.
Yeah, I mean, of course, we're checking blood work before every infusion. We still do that no matter how many years you've been on it. We're checking blood work to make sure there's no inflammation of the liver, to make sure the kidney function is okay. But actually, in general, if a patient's going to have one of these severe, 1 out of 10, severe side effects from immunotherapy, it typically happens in the first 6 months. Not every time, but almost all times, if you're going to have one of these severe effects, it's going to happen earlier on. I do not generally see patients that are 3 years out getting a out of the blue new side effect from immunotherapy. It just doesn't happen.
Great. Well, this is good to know. Well, we're coming towards the end of our program, and I think you've covered most of the other questions. There's a question in here about, is there a difference between the side effects or the effect of Keytruda and avelumab, and which one might have more side effects? Like, how do you, as the clinician, pick, because you can prescribe all of the different approved treatments, how do you decide which one each patient should go on?
Yeah, it's a really tough question, and it gets a little bit technical in the answer. I will say that we think maybe some of these 4 immunotherapies have small differences in their side effect profile. Whereas some patients might be less likely to get, for example, the lung reaction with certain of the drugs compared to others. But in general, they probably are all about the same. The one that has stood out and probably gets the most common use is pembrolizumab, the Keytruda drug, because that drug has had a definitive trial, in patients with metastatic disease that showed that it really elongated the survival for patients, whereas some of the other drugs haven't shown that. The avelumab drug has shown that survival benefit as a maintenance, like we talked about. So most of the time, if your doctor's thinking about that maintenance strategy right after chemotherapy, going into a maintenance immunotherapy, avelumab has the best evidence. For patients that have been through chemo and they kind of adopted that wait and see, and then the cancer came back, pembrolizumab has sort of the best evidence. And I think oncologists always want to use the drug that sort of has the best evidence around it for a given treatment setting. So that's probably how we end up picking.
Wow. So I think this has been an incredibly useful program. I'd like to thank you, Lynn and Andrew, for sharing your stories and your experiences. And Dr. O'Donnell, as always, you're amazing. We appreciate your sharing all of this information. And I'm going to go ahead and shut down our program.